Lipsa is here? Okay. She's going to present a case of atypical thyroid associated orbitopathy.
Good morning everyone. Today I am going to present a case of thyroid associated ophthalmopathy. Change नहीं हो रहा है. A 45-year-old Hindu female came to our ophthalmology OPD with chief complaint of watering right eye since 3 months with upward deviation of eyeball, pain and upward movement of eyeball. There is no significant past history. On ophthalmic examination there is right eye proptosis, upward displacement of eyeball, restriction of eye movements on right eye in superior temporal and inferior temporal inferior quadrant. There is upper eyelid retraction and left eye hypophoria is seen in on-cover test. The patient is unable to converse both the eyes, and on exophthalmometry of right eye, the distance between the lateral orbital margin to the center of corneal reflex is 23 mm and of left eye is 18 mm. For the right eye hypertropia, the Parkes three-step test was performed. In first step, in primary case there is right eye hypertropia, and in second step hypertropia is increasing in right case and also increasing in right head tilt. This is the extraocular muscle movement before receiving the treatment. On examination of anterior segment, the conjunctiva was normal in both the eyes, cornea was clear, anterior chamber was within normal limit, pupil is reacting to both direct and consensual light reflex, and on lens there is NS grade 1 is present. The visual acuity of right eye was 6/18 and of left eye was 6/24, which is improving on pinhole to 6/6. Intraocular pressure was 15 and 16 of right eye and left eye respectively. Color vision was normal. So what can be the other causes? My differential diagnosis are any maxillary sinus tumor or any optic neuritis, as there is painful extraocular muscle movement was present, and or any left eye inferior oblique palsy. On investigation, there is on CBC microcytic hypochromic anemia was present, TSH was below the normal limit, that is less than 0.01, T4 was above the normal, that is 13.33 microgram percentage, and T3 was 1.82, and parathyroid hormone was within normal limit. The incisor brain orbit was normal. MRI brain and MRI orbit showing right eye bulky inferior medial superior rectus muscle and left eye bulky superior rectus muscle. So patient was received with tablet carbimazole 5 mg, injection methylprednisolone 500 mg for 5 days, injection pantoprazole and injection methylcobalamin. So hypertrophy of right eye was improved after 5 days of injection methylprednisolone, and also extraocular muscle movement was also improved after receiving the treatment. So my take home message was early diagnosis and treatment can lead to better outcome. Thyroid associated ophthalmopathy may mimic maxillary sinus tumor, so it should be kept in mind as differential. It is important to take radiography picture, blood thyroid profile for timely diagnosis and management, as there are different protocols for other differentials. Thank you.
Thank you. Any comments by anybody? Sir, Dr. Trisal, sir.
Hello. I think since they have done the thyroid profile and manage it conservatively, sir, how much these methylprednisolone is helpful? Is it really indicated?
Yeah. So, Vishal, do you want?
diplopia associated with it, and it doesn't resolve with this methylprednisolone 3 cycles as well. Then we also chip in other immunosuppressive agents along with it.
You have to start with clinical activity score. either Ugogo or CAS, so that possibly was not done because you're not suspecting that the patient may have thyroid eye disease. It was a little atypical because it was mostly unilateral presentation, right? So unilateral presentation, especially in India, is about 30% of patients. When they present to you, it is unilateral. And over a period of time, they may develop symptoms and signs in the other eye. Even in unilateral patients, you have to suspect thyroid eye disease when there is lid retraction. There are very few causes for proptosis with lid retraction, one of which, of course, is thyroid ophthalmopathy, the most common, right? And after that, you have to do clinical activity score to know what is the level of activity and also determine the severity. There is a nice Ugogo classification which tells you what is the activity and what is the severity. In this patient, activity was mild, whereas severity was also moderate to severe. In such a situation, what you have done is right. Intravenous methylprednisolone has been given for 5 days, that's fine. But follow-up treatment is very important. Treatment doesn't end here, treatment only starts here. So you have to give 3 weekly cycles, or if you follow the Ugogo protocol, you have to give weekly cycles for 6 cycles and then reduce the dose to 250 milligram and continue the treatment, and immunomodulation as well. Otherwise, it will rebound. This is a disease that is not treated at one episode or one time. It has to be a prolonged treatment for 4.5 to 6 or 6 months or even beyond. And finally, if she doesn't resolve, obviously, orbital decompression followed by extraocular muscle surgery, finally followed by lid surgery. That is only in the inactive phase. Any other comments?
To be done after the control of inflammation to some extent, or at the active phase itself?
Immunomodulation is, there are 2 ways of doing it. Either you follow the Ugogo protocol or the low dose IVMP protocol by Rootman, that which I feel is better in Indian circumstances because we want to prolong treatment rather than cut the treatment short to 6 weeks. Our need for decompression is much less compared to Caucasians, right? So what we do is we start with intravenous methylprednisolone, 3 weekly protocol. At the end of 3rd pulse, when the patient comes for the 4th pulse, you assess activity and severity. If it is significantly resolved, then you don't have to start on immunomodulation at all. If it is not significantly resolved, then you start immunomodulation along with the 4th pulse of IV methylprednisolone, and you either give azathioprine or mycophenolate mofetil depending on the patient profile. That is continued for at least 6 months. Azathioprine dose that is followed is 50 milligram twice a day. Mycophenolate mofetil is 500 milligram twice a day, and that is given up to 6 months minimum. And then only you think of surgery unless the patient has compressive optic neuropathy or corneal decompensation where surgery can be done early. That is a protocol. And especially in smokers or young males, then the chance of rebound is much higher. Otherwise, in the West it is young females, but here in India it is the young males and smokers have the highest possibility of rebound. In them, possibly you have to prolong the treatment to little longer, if they don't give up smoking, that is. And selenium can also be added. Alcoholics, I really don't know whether it is it matters or not, but there is no such information. Thank you so much.